Hi, everyone. Today we are talking about Chapter 10, the respiratory system. Talked a little bit about a few things when we went through the cardiovascular system and the exchange of oxygen and carbon dioxide between the heart and the lungs and the bloodstream, but we're going to go in a little more detail for this chapter. So, an overview of the respiratory system. It ensures that oxygen enters the body and carbon dioxide leaves. It is the basic requirement of every respiratory system. During inspiration or inhalation, air moves from the atmosphere into the lungs through cavities and tubes. And then during expiration or exhalation, air moves from the lungs to the atmosphere via the same structures, just backwards. Ventilation is what breathing is officially called, inspiration and expiration put together. It depends on the cardiovascular system to transport oxygen from the lungs to the tissues and carbon dioxide from the tissues into the lungs and then back out. During cellular respiration, cells use up oxygen and produce carbon dioxide to put back into the bloodstream and be exhaled as waste. Homeostasis. All of our systems are designed to maintain homeostasis for us. The ways the respiratory system works with the cardiovascular system to maintain that homeostasis. External respiration, or the exchange of gases, the oxygen and the carbon dioxide between the air and the blood. It facilitates that process. Transport of gases to and from the lungs, and then to the tissues and the cells of the rest of our body. And then internal respiration is the exchange of gases between the blood and tissue fluid. Next section, we are talking about the upper part of the respiratory tract. The upper respiratory system consists of the nasal cavity, the oral cavity, the pharynx, and the larynx. So the nose opens at the nares, which are the official sciencey name for your nostrils, which leads to the nasal cavity behind. The nasal cavities are separated from each other by a septum that is composed of bone and cartilage. We have hair that filters and traps small particles so they don't enter the air passages. Of course, there are times where they get past that, and that's when we feel that little tickle and we try to sneeze it out. It's our body's way of saying, hey, something shouldn't be there. Let's get it out. But that's one of our first line of defenses. Our nasal cavity is lined with a mucous membrane. The mucus helps trap particles and move them to the pharynx, where they can be swallowed or expectorated, which is the fancy science word for spit. Under the mucus layer is the submucosa, which contains a lot of capillaries that help warm and moisten the incoming air. The abundance of capillaries makes us susceptible to nosebleeds. They're very, very thin and fragile. The nasal cavity contains certain odor receptors. Tear glands in the eye drain into the nasal cavities by way of tear ducts. That's why crying will cause a runny nose. The nasal cavities also connect with the sinuses of the skull. Fluid may accumulate in those sinus chambers, causing an increased in pressure and a sinus headache. Air in the nasal cavities passes to the nasopharynx, which is the upper portion of the pharynx. That is how you say that word, pharynx, not pharynx, pharynx. Auditory tubes, officially called eustachian tubes, will connect the nasopharynx to the middle ear. When air pressure inside the middle ear equalizes with the air pressure in the nasopharynx, the auditory tube openings may create a popping sensation. It's also why we tend to get ear infections when our sinuses are backed up. When we have a cold or a flu and our sinuses are backed up, it gets backed up into those eustachian tubes and can cause an ear infection. The pharynx is a funnel-shaped cavity that connects the nasal and oral cavities to the larynx. It has three portions: the nasopharynx, the oropharynx, and the laryngopharynx. Laryngopharynx. Tonsils are made of lymphoid tissue at the junction of the oral cavity and the pharynx. They provide defense against inhaled pathogens, as well as they are made of lymphatic tissue. The larynx is a cartilaginous structure between the pharynx and the trachea. The Adam's apple, or the laryngeal prominence, as it's officially called, is located at the front of the neck. It houses our vocal cords, which are mucosal folds that are supported by elastic ligaments. When food is swallowed, the larynx moves upward against the epiglottis, which is a flap of tissue that prevents food from passing into the larynx. So we have two tubes. We talked about it when we talked about the digestive system last chapter. We have the esophagus and the trachea run parallel side by side. We don't want to get food in the trachea, so that flap comes to cover it, the epiglottis. Vocal cords is the opening between the vocal cords is called the glottis. When air passes through the glottis, the vocal cords vibrate and produce a sound. The greater the tension in the vocal cords, the higher the pitch. When the glottis is wider, the pitch is lower. The loudness depends on the degree to which the vocal cords vibrate. And that is a picture of somebody's vocal cords making noise inside their body. The lower respiratory tract. You have the trachea, the bronchi, and the lungs. All the structures in there. The trachea is commonly called the windpipe. It's where the air moves in and out every second of every day. Connects the larynx to the primary bronchi. Its walls are reinforced by C-shaped cartilaginous rings, which prevent the trachea from collapsing. The C shape allows the esophagus to expand into the trachea when swallowing. The cells of the trachea, they are lined with pseudo-stratified ciliated columnar epithelium, as well as goblet cells. If you remember way back from, I think it's chapter 4 when we talked about all the tissues, pseudo-stratified means the stratified are the flat-looking cells, but they don't look layered. I'm sorry, they do look layered, but they're not actually layered. That's just one layer of cells. They all connect to that bottom basal membrane, but it looks like there's many layers of them because of the placement of the nuclei. So it's fake stratified. And then ciliated means there's cilia on top. Columnar means they look like little columns. And then epithelial tissue. The goblet cells produce mucus, which traps debris from the air as it passes through the trachea. The mucus is then swept away from the lungs and toward the pharynx by the cilia. Smoking damages the cilia, causing smoker's cough. A tracheostomy is a breathing tube inserted into the trachea. There used to be a horrifying commercial of smokers that used to have the breathing tube because they damaged their trachea too much, so they can't really use it anymore. The lungs are made up of the secondary bronchi, bronchioles, and alveoli. The right lung has 3 lobes, while the left lung has 2 to make room for the heart. Each lobe is divided into lobules. Each lung is enclosed by pleurae, which are 2 layers of serous membrane that produces serous fluid. So it's just like a sac that lines the entire lung. The bronchial tree, it looks like an upside down tree. The 2 primary bronchi lead from the trachea into the lungs. The primary bronchi branch into secondary bronchi, which continue to branch until they are small bronchioles, about 1 millimeter in diameter. Bronchi have cartilage like the trachea, but as they get smaller and smaller, the cartilage disappears. Alveoli or alveoli, however you want to say it. Each bronchiole leads to an elongated space enclosed by many air sacs called alveoli. The lungs have about 300 million of them. Each alveolar sac is surrounded by blood capillaries. The walls of the sac and the capillaries are both made of simple squamous epithelium, so just a single layer of tiny flat cells. Gas exchange occurs between the air and the alveoli and blood in the capillaries. Oxygen diffuses across the alveolar wall and enters the bloodstream. Carbon dioxide diffuses from the bloodstream into the alveoli. The alveoli are lined with surfactant, a film of lipoprotein that lowers the surface tension of water and prevents the alveoli from closing completely. Infant respiratory distress syndrome is when premature infants don't make enough surfactant, the alveoli collapse. That's why when babies are premature, they're especially concerned about the baby's lungs if they're going to work properly. The actual mechanism of breathing. Ventilation, like we said, consists of 2 phases. Inspiration moves air into the lungs, expiration moves air out. Normally, there's a continuous column of air from the pharynx to the alveoli of the lungs. Every second of every day, your body is doing this, or it should be. The thoracic cavity. The lungs lie within the sealed thoracic cavity. The rib cage is the top and the sides of this thoracic cavity. There are intercostal muscles between every single one of your ribs. I know we're used to seeing when we think of ribs, we're used to picturing a skeleton and there's nothing in between the ribs. But in reality, you actually have muscles in between every single one of those ribs. They're called intercostal muscles. And if you eat ribs of pork ribs or beef ribs, you are actually eating the intercostal muscles of that animal. The diaphragm is the floor of the thoracic cavity. That's where the border is. The lungs adhere to the thoracic wall by way of the pleura, the sacs help it stick to the cavity. And the space between the two pleura is minimal and filled with pleural fluid. Ventilation is governed by Boyle's law, which states at a constant temperature, the pressure of a given quantity of gas is inversely proportional to its volume. So this relationship controls inhalation and exhalation. The higher the pressure, the less volume of air there is in our lungs. Then we take a breath and we fill our lungs with a volume of air that the pressure gets smaller. Inspiration is the active phase of ventilation. The diaphragm and the external intercostal muscles will contract. In its relaxed state, the diaphragm is dome-shaped, but during inspiration, it contracts and becomes flattened. Contraction of the external intercostal muscles cause the ribcage to move up and out. Both of these actions will increase the size of the thoracic cage. As the thoracic volume increases, the lungs volume increase as well because the lung adheres to the wall of the thoracic cavity. As the lung volume increases, the air pressure in the alveoli decrease. Alveolar pressure is now less than atmospheric pressure, so air flows from outside of the body into the lungs. Expiration is the passive phase of breathing. The diaphragm and external intercostal muscles relax. The rib cage returns to its resting position, moving down and inward. The lungs recoil and the air pressure inside increases while air flows out. Surfactant keeps the alveoli from collapsing during expiration, so they don't close completely. The bubbles don't pop. Also, as the lungs recoil, the pressure between the pleurae decreases, and this keeps the alveoli open. When in an incident, the thoracic cavity is punctured, what we know as a punctured lung, air enters the space between the two pleurae, which causes the lung to collapse. Maximizing, breathing hard, maximum inspiratory effort uses muscles of the back, chest, and neck. It increases the size of the thoracic cavity more than usual, allowing maximum expansion of the lungs. Expiration can also be forced, like singing or blowing air out. Contraction of the internal intercostal muscles forces the ribcage downward and inward. Also, when abdominal muscles contract, they push on the abdominal organs, which push upward against the diaphragm, forcing air out. Volumes of air exchange. So the tidal volume is the amount of air that moves in and out with each normal breath. The vital capacity is the maximum volume that can be moved in plus the maximum volume that can be moved out in one breath. So taking the deepest breath you can and then exhaling as much as you possibly can, you can actually measure that volume of air, and that's called the vital capacity. Inspiratory and expiratory reserve volumes, IRV and ERV for short, is the increased volume of air moving in or out of the body with forced inspiration or expiration. So you breathe into a spirometer, it will measure your breaths. If you look at the beginning, there's some even breaths, those are normal breaths, and then this person took a really deep breath for maximum inspiration and then blew all that air out for maximum expiration, and you can actually measure that with a spirometer, and that will be their vital capacity. Vital capacity is the sum of the tidal volume, the ERV, and the IRV. There is some inhaled air that never reaches the lungs. It fills the nasal cavities, trachea, bronchi, and bronchioles. These passages are not used for gas exchange. They contain dead air space. The residual volume is the air remaining in the lungs after exhalation. And control of ventilation. Can we control our breathing? To a certain extent, yes. So respiratory control center in the brain automatically sends out nerve signals to the diaphragm and the external intercostal muscles of the rib cage, causing inspiration to occur. When the respiratory center stops sending nerve signals to the diaphragm and the rib cage, the muscles relax and expiration occurs. So we have these tiny little nerve centers in our brain throughout the pons and the medulla that control our breathing. The pons respiratory centers, the pneumotaxic center, the apnoistic center, and the medullary respiratory center has the other three spots, dorsal and ventral respiratory groups. Although the respiratory center automatically controls the rate and depth of breathing, it is influenced by the nervous system. We can voluntarily change our breathing pattern for speaking, singing, eating, and swimming underwater. Following forced inspiration, stretch receptors in the airway walls will initiate inhibitory nerve impulses that stop the respiratory center from sending out nerve signals and overstretching the lungs. Sudden infant death syndrome is what SIDS stands for. It's what happens when an infant under 1 year is put to bed, seemingly healthy, and sometime while sleeping, the child just stops breathing. The cause of SIDS is not known, but vaccinations, vomiting, and infections have been ruled out as factors. None of those things cause SIDS. It might be a miscommunication between the respiratory center of the brain, all those little tissue spots, and the lungs. Chemical control of breathing. Cells produce carbon dioxide during cellular respiration. Carbon dioxide then enters the blood where it combines with water, forming an acid that breaks down and gives off hydrogen ions. If you remember when we talked about it in chapter 2 or 3, hydrogen ions, the more hydrogen ions there are in something, it will decrease the pH, in this case, of our blood, which means it makes our blood more acidic. Chemoreceptors are sensory receptors that are sensitive to the chemical composition of body fluids. And we have chemoreceptors that are constantly monitoring the pH of our blood, making sure that it is within a normal range, which is a very small range. Two sets of chemoreceptors that are sensitive to pH can cause breathing to speed up. One set is in the medulla oblongata of the brainstem. The other set is in the carotid bodies of the carotid arteries and the aortic bodies of the aorta. These chemoreceptors mostly respond to carbon dioxide levels in the blood. When blood pH decreases, the respiratory center increases the rate and depth of breathing to remove carbon dioxide from the blood. This will increase the pH so the breathing rate returns to normal. When you hold your breath, carbon dioxide begins accumulating in the blood, thus decreasing the pH and making it more acidic. The respiratory center, stimulated by the chemoreceptors, is able to override a voluntary inhibition of respiration, forcing you to breathe. So when you hold your breath and you finally get that urge to breathe and your body forces you to breathe, it's because there's too much carbon dioxide in your blood and your blood has become too acidic, and we need to immediately reverse that. So it's not because our body needs oxygen, it's because our body's trying to get rid of carbon dioxide because it's making our blood too acidic. And then gas exchange in the body. Oxygen is needed to produce ATP, so it must be supplied to all cells. Then carbon dioxide is produced and it must be removed. Respiration includes the exchange of gases not only in the lungs, but also in the tissues. The principles of diffusion govern whether oxygen or carbon dioxide enters or leaves the blood. So gases exert pressure, and the amount of pressure each gas exerts is called its partial pressure, and it's symbolized with a PCO2 for the partial pressure of carbon dioxide, or PO2 for the partial pressure of oxygen. If the partial pressure of a gas diffuses across a membrane, it will diffuse from a higher to a lower partial pressure. That is a normal thing with those particles. If it starts off in one place, eventually it's going to diffuse and fill whatever space there is. And that's how it works with oxygen and carbon dioxide between your blood and the air. External respiration is the exchange of gases between the lungs and the alveoli and the blood capillaries. The partial pressure of carbon dioxide is higher in the lung capillaries than the air. Thus, CO2 will diffuse out of the blood into the lungs. The partial pressure of CO2 is the opposite. I'm sorry, that should say the partial pressure of O2 is the opposite. I'm going to do that. The partial pressure of oxygen is the opposite. So oxygen will diffuse from the alveolar air into the red blood cells in the pulmonary capillaries. So external respiration. We always have these nice chemical equations to go with our processes that happen in our body. Most of the carbon dioxide is carried in plasma as bicarbonate, HCO3 minus. In the low partial pressure environment, the lungs, this reaction will proceed to the right. So hydrogen ions combine with bicarbonate to make carbonic acid. Carbonic acid comes into contact with carbonic anhydrase. It will split into water and carbon dioxide. So carbonic anhydrase is the enzyme that will speed the breakdown of carbonic acid into the water and the carbon dioxide. Hyperventilation, breathing at a very high rate, pushes the reaction to the right. So blood has fewer hydrogen ions. It will make it less acidic and bring the pH back up to normal. Hypoventilation is when breathing happens at a low rate, pushes the reaction to the left. And acidosis, which is low blood pH, can occur when the blood is more acidic. Pulmonary capillary blood is typically low in oxygen, and alveolar air has a higher partial pressure of oxygen. Therefore, oxygen diffuses into the plasma and then into the red blood cells in the lungs. Hemoglobin takes up that oxygen and becomes oxyhemoglobin. So the signal for hemoglobin is Hb. If it doesn't have an oxygen, it's called deoxyhemoglobin. Once we add oxygen and they all combine, we call it oxyhemoglobin. The exchange of gases between the blood and systemic capillaries and the tissue cells. Blood entering systemic capillaries is bright red because red blood cells contain that oxyhemoglobin. After oxyhemoglobin breaks down and gives up that oxygen, it diffuses out of the blood and into the tissues. Internal respiration. This is when oxygen diffuses out of the blood into the tissues because the partial pressure of oxygen partial pressure of the oxygen of the interstitial fluid is lower than that of the blood. The lower partial pressure of oxygen is due to the cells continuously using up oxygen during cellular respiration. Carbon dioxide will diffuse into the blood from the tissues because the partial pressure of oxygen in interstitial fluid is higher than that of the blood. Carbon dioxide is produced during cellular respiration and collects in interstitial fluid. This is just an overview. Oxygen coming in, gets diffused into the blood will push carbon dioxide out, and then we exhale it out. Just an oversimplified version of what's happening. And it's all being driven by diffusion. Where is the high concentration wanting to diffuse into the lower concentration? And then disorders. We've talked about a few, but this section is all about disorders. So, disorders of the upper respiratory tract infections can spread from the nose, nasal cavities, pharynx, and larynx to the sinuses and the middle ears. The upper respiratory tract is susceptible to viral and bacterial infections because it is responsible for filtering out those pathogens and other materials in the air. And sometimes we don't filter out those pathogens enough, and they will cross into our bloodstream and spread. Viral infections, viruses that cause cold or the flu. Sinusitis is the blockage of sinuses. Tonsillitis, inflammation of the tonsils, is considered an upper respiratory tract infection. And then laryngitis, the infection of the larynx, can lead to voice loss. Lower respiratory tract disorders include infections, restrictive pulmonary disorders, obstructive pulmonary disorders, and lung cancer. Acute bronchitis is the infection of the primary and secondary bronchi. Pneumonia is can be bacterial or viral in cause. During pneumonia, the bronchi and alveoli will fill with thick fluid, so they don't work properly. And then tuberculosis is a bacterial infection that can lead to tubercles, which are those encapsulated bacteria we saw a couple chapters back. During restrictive pulmonary disorder, where breathing is restricted, vital capacity is reduced, lungs have lost elasticity. Pulmonary fibrosis is when fibrous connective tissue builds up in the lungs, usually because of inhaled particles like sand, coal dust, asbestos, or fiberglass. The lungs cannot inflate properly and can lead to cancer. Obstructive pulmonary disorders, when the pathway is obstructed, when air does not flow freely in the airways. Chronic bronchitis, emphysema, and asthma are all collectively referred to as chronic obstructive pulmonary disease, or COPD, because they tend to recur. Chronic bronchitis, airways are inflamed and filled with mucus. The bronchi will undergo can undergo degenerative changes, including the loss of cilia. Smoking is the most frequent cause, but exposure to other pollutants can also cause it. Emphysema is chronic and incurable. Alveoli are distended and their walls are damaged. The surface area for gas exchange is reduced if the alveoli are damaged, so less oxygen reaches the heart and the brain. Again, most often caused by smoking. The elastic recoil of the lungs is reduced, so not only are the airways narrowed, but the driving force behind expiration is also reduced. The lack of oxygen to the brain can make the person feel depressed, sluggish, and irritable. Severe emphysema may be treated by lung transplantation or lung volume reduction surgery. A third of the most diseased lung tissue is removed, which enables the remaining tissue to function better during this surgery. And asthma. Symptoms are wheezing, breathlessness, and sometimes a cough and the spitting out of mucus. When exposed to an irritant like pollen or tobacco smoke, the smooth muscle in the bronchioles spasms. Asthma is not curable, but it is treatable with special inhalers. So you can see the picture. A normal airway versus an asthmatic airway is a little bit closed, and then an asthmatic airway during an attack is really, really obstructed. Lung cancer is more prevalent in men than women. The first event in lung cancer is the thickening of the lining of the bronchi. Then cilia are lost and making it impossible to prevent dust and dirt from settling into the lungs. Following this, cells with atypical nuclei will appear in the lining. A tumor made of cells with atypical nuclei is considered cancer in situ, or cancer at one location. And the final steps occurs when some of these cells break loose and penetrate other tissues, called metastasis. The original tumor may grow until a bronchus is blocked, cutting off the supply of air to that lung. A pneumonectomy, a removal of the lobe or the whole lung, needs to be performed before metastasis occurs for the best prognosis. And just as a last picture, on the left, that is a picture of a normal, healthy lung. On the right, that is a picture of a lung with lung cancer. It is not pretty, so don't smoke.